Well, hello. Hello again. Welcome to this edition to the Mayor's Emergency Response Roundtable. I'm Rick West, and I am so pleased to be here with two of our leaders in the health field here in Chesapeake, our Chesapeake Health Director, Dr. Nancy Welch, and our CEO of Chesapeake Regional Healthcare, Reese Jackson. Welcome, both of you. So before we begin, I do want to take just a moment to thank the thousands of city employees who are out here, have been for the last 6 months, working, risking themselves, doing their jobs to make our lives continue to be enjoyable. They have been just an inspiration in keeping us going, providing services that we would not have if it wasn't for their dedication. I'm so proud of the fact that our city has been open through so much of this virus and doing it safely. We certainly have had our bumps, but we are continuing to provide services to our citizens in the best way we can. So, as I've said before, these roundtables are here for our citizens to hear from the experts, the rationale for making decisions, the understanding of where things are. And so it's the roundtables are here for you as citizens. And having said that, let me go to our health director, Dr. Welch. Dr. Welch, I looked at some the graphs that you brought for us today last night and saw some fascinating stuff there. I think one of the things that I keep hearing on social media is this confusion about where we are, about the positivity rate, and I think you have said all along that's one factor, but there are other factors in terms of trends. And after I looked at those graphs last night or this morning, I started to see the picture, even though I've heard you say that on several other occasions. So please take this opportunity to explain to us exactly what you're talking about.
Sure, and I'm glad you used the seeing the trends term, and because public health and epidemiology, even though we use a lot of math and statistics, it really is telling a story. That's the whole point of all this information. And right now, the antagonist in our story is COVID. So there is a lot of confusion about the positivity. And at the beginning, positivity was a more accurate assessment than it is today. And let me explain what I mean by that. First of all, let me define what positivity is. It's basically a percent, and it's looking at the numerator, which is the number of positive cases, over the denominator, which is the number of positive plus negatives. Initially, there were only a limited number of labs that could do the test, and so all the positives and negatives were able to be entered into the system, and so positivity was a bit more accurate. And Heath, if we can go to the first slide, I'll show you some of what I mean. This was a slide looking at positivity rate in Chesapeake, and it was September 7th. That big surge at the beginning is when our testing only permitted us to do asymptomatic, so we would expect a whole lot of positives. But actually that was a pretty accurate percentage because we had limited labs who could do the test. As you know, over time, there have been many, many more labs, even some testing that can be done at home that have occurred. And people understand the value of positivity or positive lab tests because we follow up on positive lab tests. That's what we're doing, perhaps our isolation and quarantine and contact investigating. As we have had such a surge in labs doing the test, it also has made it more challenging to report all of the test. So the labs will report positive because they recognize that's important, but then the negatives may come later in the evening or when they have time in a surge of the negative. So what that means is that a bottom denominator figure, positives plus negatives, is not an accurate figure.
Okay, so I guess, as you explained that, I go back to my sporting days of you think about the at-bat. A baseball player is rated by his hitting percentage. So if you only counted the times you got a hit and didn't add the times you struck out, you would get a high batting average, all right? And so from a sports standpoint, you want to count the number of times that you actually struck out and got a hit in order to get a correct batting average. So pretty similar?
Boy, I'm glad you brought that in. I've been trying and trying to come up with an analogy, and I played softball. But perfect analogy, because that's exactly what it is, and that's what we're seeing on this slide. Because if you go to the, you see the surge, and so you get frightened by this slide with this surge. But if you go to the next slide, this is dashboard the next day, the very next day. And the bottom figure is the positivity. You notice that little bump up there is what we saw as that big surge, which looked really bad. But obviously what happened is more of the information, or the strikeouts, were entered in the data, and so it gave a truer denominator figure. And so this is why on positivity, you can see it's less than 10%, it's 7 point some percent, that was on the 8. I look at trends.
So that is, I mean, that's what you've said all along. So we've looked at the trees. Now let's look at the forest. We're talking about trends of where things are going. What is the total story? How good is that? How much is the baseball player contributing to the victory of that ball game, right?
Ooh, I love your analogy. My brother, who played college baseball, would love it as well. Yes, absolutely. That's exactly what it's about. And this is why, if you look at the top slide there, that's actually a data metric that I follow more closely. And this is the daily incidence, meaning new cases, new positive cases. It's the daily incidence, and what they've done mathematically is per 100,000 population. And we do things like that in, say, infant mortality, where we say number of infant deaths per 1,000 births. What this mathematically is doing is establishing as if every locality has a population of 100,000. So then it says, okay, if your population is 100,000, what would be the new cases? And so the only thing that you have to really have reported is the positive cases. You're not into the negative. So it makes it much more realistic. It makes it much more consistent with a more expedient reporting of positives than negatives. And so again, this is looking at trends, but I find this is something I watch more closely, to be honest. And if you turn to the next slide.
So just one second
go
about
right
that.
ahead.
So a lot of people get that information. I myself have got addicted to looking at the first page in the pilot, turning to the inside page, and you look at, are they actually reporting, what are they reporting?
They're reporting positivity. And so, to be honest, and again, it can be, I know it, because when I look at the numbers, I know that some of it is delayed and behind. So, and it doesn't, in my mind, my concern with that reporting is it's showing one day. It's just like you saw on that first slide, you had that surge, but the very next day gave the rest of the story, because the rest of the information was provided. And we cannot have a myopic view. Public health and epidemiology is about the story. It's about following the trend. It's about the narrative. And that means that we have to have the complete picture, and it has to be over time. So, for example, as this shows, and you look at this next slide, this is per 100,000, and if you do the next slide too, Heath, this is a weekly incidence rate per 100,000. So it's just like what we mentioned on the daily rate. You only have to be reporting the positives, and it's mathematically made every locality like 100,000 population. And I would think you don't have to be a mathematician, epidemiologist, public health. You can be any field, and you see that's a good downward trend. And I'm pleased with that downward trend.
Did I see that you noted there were more than the 14, like 40 days of downward trend? Is that correct?
That's correct. And we look at, I mean, and again, yes, you have some little blips in there, but there's what we call a trend line. It's not marked on there, but you can visualize the way that line goes. Again, you don't have to be very specific about it to know that that is a downward line that slope of the line goes downward. And so that's really what we're looking at, is the trend. And I prefer this information because it's only requires positive reporting. And if you go to the next slide, I've sort of summarized it. When you look at the incidence, again, which is new cases, it's not cumulative, it's new case rate versus positivity. With the incidence, you only requires the positives. So if there are delays in reporting negatives, it will not affect your metric. It will not affect the assessment of it. And then the denominator is a constant 100,000 population. Positivity, to be accurate, you have to have concurrent reporting of positives and negative. And that was good, fine at the beginning because it was possible. But with the expanded testing and expanded number of labs, it's very difficult to achieve that.
Well, so it sounds like we're headed in the right direction.
I think so.
Okay. I think another way that many of us look at where we are, telling that story, we look at what's the impact of our hospitals. And we're, again, so glad you could be here, Reese, to, excuse me, but give us kind of a snapshot of what's happening at Chesapeake Regional.
Okay. And just to special shout out to Nancy and her staff. You know, we work very closely with Nancy and her staff each and every week, and we do also look at the data that she's just shared. We have two different types of lab tests. One we refer to as the rapid test. It's a test that we do internally. Sometimes supplies are in short demand. We don't always have the ability to use the rapid test. We use it as much as we can. We do prioritize its use. We also have an external lab that we also send out, and the turnaround times for that test are good, but not as good as the rapid test. So when we're testing someone that comes to the hospital, in comparison and keeping up with the baseball theme, they're more likely to get a hit, right? They're symptomatic. So we do see similar patterns that correspond to Nancy's trends. We saw recently, in the past month or two, a higher positivity rate of the persons we test. And we're now beginning to see a declining positivity test of the persons that we test. But the slope of our hospitalizations, the admissions and the discharges, there's always a lag. So, you know, particularly the downward slope. Persons have a long length of stay. This is not an easy disease to combat. So we did see a rather sudden increase of admissions a couple of months ago, about 6 weeks ago, actually. And we are optimistic that we're seeing a downward trend. You know, that is our belief that we're seeing a downward trend, particularly based on Nancy's numbers. And but we've been very busy at the hospital. It's been very challenging, but we've done very, very well. All of our employees, you know, bring many gifts to the table. The frontline workers have, you know, in particular, have been there for the patients, providing the direct patient care. So across the board, it's been a team effort, and we've responded well to the challenge.
So I guess this question is to both of you. There's, I guess, a lot of misinformation out there. What are we doing to try to clarify other than having a round table? Dr. Welch?
Well, we, as you may or may not have noted, we have decreased our community testing. And a lot of that is because what we have a sense now of where some of the main areas are. We have a sense now of a difference in different cultures and nationalities in terms of percentage at risk. So now our real focus is to work on the precautionary measures. That, and we said this at the very first roundtable, that what is making the difference, or what will make the difference, or what will determine success and safety and save lives, is our compulsive adherence to precautionary measures. This is a behaviorally driven, behaviorally controlled disease. So we are collecting and have ordered from the city a number of masks, and we have a meeting coming up. So our community mass meetings, so to speak, or mass events, are going to be far more focused on spreading the word, on engaging people, on basically how we can have each other's back. Very new necklace, very easy precautionary measures that we can do. But we have shown, and I didn't point it out in the other slide, but we've shown we can do it. We have flattened the curve, and it was because people did comply with the recommendations. But then they got worn out at doing it and became lax, and you saw the difference. It went up, and we had to have restrictions imposed. But I want us to get out there and open up our businesses and other entities, but I want it to be safe. And countries like Denmark, Japan, South Korea, they've shown you can do it.
So how is all this affecting the hospital, Reese?
Well, I would agree with what Nancy had to say just to begin with. Where are the alternatives, right? That vaccine, maybe it's around the corner. It seems to be promising, but it's not here in the present. Herd immunity takes a long time to achieve. So where are the alternatives? That is the best alternative, is to do what she said. The only thing that I would say in addition to that, because we've also collaborated with other hospitals to get out and promote, social distancing, hand washing. I would never forget the importance of hand washing, in addition to wearing the mask. But also don't wait. The youngest death that we've had was age 43. Okay, that's unusual. That's not, fortunately, that's unusual. But in all likelihood, that death could have been prevented, if someone had come to the emergency room sooner than later. So I think the only other message I would say is don't ignore your own signs and symptoms. If you're beginning to feel ill, don't chance it.
So one of the, I guess, themes I hear both of you saying is that it's right to feel optimistic, but at the same time, it's not time to let go and go back to normal without certain precautions. It's about balance. And so while we want to keep people informed, to do the things that you just mentioned, we also want them to feel positive about what the future is and the direction that we're headed, correct?
Right, and let me add to this, and sometimes what people don't realize is that, especially social gatherings, I've mentioned before that right now we're seeing the epilink to social gatherings, and people are not wearing masks, et cetera. And what people need to put in context is that when you are at a social gathering with you, I'm also at a social gathering with everyone else you've had contact with, because you could have come in contact with someone, not have symptoms. That's not unusual. We have a lot of asymptomatic individuals, but you could be contagious without knowing it. And maybe I should or should not use this analogy, but we use it in STDs, sexually transmitted diseases, that when you have sexual activities with an individual, it's not just with that individual. It really is with any other individual. And social gatherings are the same. We have to remember that. No symptoms does not mean that this person is not bringing the germ to the party.
So I guess it's too early to tell, I'm sure from the hospital's perspective, but also from your data, whether Labor Day has had any kind of a negative effect. I know in my family, we had used the Labor Day weekend to sort of spread out time with family. We had some family over one night, another, rather than having one large. But I think you're right in terms of the family gatherings. From what I've seen, you haven't seen a cousin in a long time, and they come, and then all of a sudden you kind of forget about, and you take the mask, and you're talking closer and closer, or maybe crying or laughing or whatever, and it's not a time to let down, but it's awfully tempting, right?
Well, and we consider family. And we forget, but this is family I haven't seen in 2 weeks.
Right. Mm-hmm.
So it really needs to be considered in the same realm as stranger, because again, you don't know with whom they've come in contact. And because this COVID is so sneaky, and it really is sneaky, in terms of causing asymptomatic contagiousness, You just don't know where you might have been exposed.
Now, I'm a little reluctant to ask this question to both of you because I don't want, if the answer is that some parts of the city are more at risk than others, I don't want people to feel like if you live in southern Chesapeake, you can just forget all of the precautions. But are we seeing a positive results in parts of the city, in some parts of the city greater than other parts? And are we finding more hospitalizations from different parts of the city?
Zip codes 20, followed by 24, 23, and 22. Those are the zip codes that we most see in our hospital. In terms of the disease as it relates to hospitalization, where are the correlations? Age, for sure. I mean, in terms of hospitalization. So the older, age 65 and above, the more likely you are to be hospitalized. But I would not dismiss, I would not read too much into that, because we've seen a lot of middle-aged persons hospitalized at our hospital. The other factor, obviously, is chronic conditions, comorbidities, and people who are, have more than one comorbidity that are more at risk, the more apt to be hospitalized. In the city of Chesapeake, it's really no secret that the city of Chesapeake is aging. The next few years, the percent of seniors is growing, I think, 27%. Compared to other cities or counties throughout the Commonwealth, the amount of comorbidities is more prevalent than others throughout the Commonwealth. So I do think that some of the trends that we've seen are related, particularly as it relates to hospitalizations, to the patterns that already exist in our community.
Thank you. That's good information. Dr. Welch, did you want to add anything to that?
I was just going to say I concur completely, and I'm glad you raised that point, because a lot of people would say, well, why are we different from Virginia Beach or other areas? And we do have an increasing older population. Chesapeake has actually invited the older population to be here, and that plays a role because unfortunately in the United States we also have increased rates of obesity, of cardiovascular disease and diabetes, and those certainly you see in the hospital contribute to sicker individuals and higher risk. So, and when we talked about different areas, cultures and things play a role. There are some cultures where they have more people living in a household, and there are more cultures where they are the essential workers, where they're going out to the jobs. They don't have the luxury of being able to stay home. And so when you look at some of the zips that he mentioned, that's where you're going to find those populations.
So we talked about getting back to getting people out there in a safe way and in as timely manner as we can. Obviously, the schools are just opening. I assume the numbers are were too early to tell about what the impact's going to be. Any thoughts? I know you were very instrumental. I know the school system, Dr. Cotton told us when he was on last week that he consulted with you and your department about before making decisions. Any thoughts on the school openings?
Well, again, I'm comfortable with the decision. I've shown you the trend lines, and I think that's key. And I speak now as a pediatrician, not just public health. I have a great deal of respect for the need and understanding of the need for students to be in class, of the benefits of face-to-face teaching of students, especially in some of our higher risk. It's all a delicate balance. Can I say this is all going to go without any hitch? No, I can't say that. But I can say that I'm very comfortable with all the details that have been put in the plan and the way that it's being implemented, and certainly the reaching out, the unified command is a part to be sure that they have adequate supplies. And we are hiring a full-time epidemiologist who will be devoted completely to the schools. Will I think there'll be no cases? I don't think so. I think there will be. But we have norovirus every year. We have flu every year. We have other communicable diseases every year. And we will handle them in exactly the same way based upon the epi investigation as to what actions need to be taken.
So you mentioned the supplies. I think city manager told me last night that we make sure that all the school facilities have adequate cleaning supplies, which are very important in controlling this disease. So I know that one of the things that you told me earlier is that the younger folks have a less chance, especially 10 and under, of contracting and spreading the virus. And so the school's decision to let younger kids start earlier, I think it sounds like it's in keeping with the trends and the science. I wonder and I guess no one can tell what it's going to look like in 2 months or even a month and a half, but as you think about the middle and high school students, they tend to gather and get close to one another, and I think that the colleges have seen that quickly that happened, partying together and so forth, it spread. So I'm sure they're going to be a little more cautious when it comes to going to that. Is that right?
Well, you and we all have kids, right? And they've gone through the teenage years, and that's not exactly the same compliance you had with your 5-year-old. So yes, there is a difference. But again, I think it's somehow we have to learn how to speak their language, and we're still working on that, to figure out how to speak their language and to be able to have the leaders among them so that they can understand the very important role that they can play. Because yes, the less than 10, they certainly can develop the virus, but they don't seem to be as much of a transmitter. But that increases once they get over 10. The 10 to 17-year-old may be 5 times the chance of transmitting the disease. So they play an important role, and sometimes even just letting them know how important they are can make a difference.
Well, it looks like we're coming to the end. Reese, any final thoughts that you'd like to share?
Also as a parent of having a child in elementary school and in college, I do think about the differences. I do think that kids are resilient even at both of those ages. But the one thing that is always concerning is the unknown. You may gut it out at home and be back to normal after a couple of weeks or maybe less. But what are the long-term, what are the long-term effects? So we don't know the unknown yet, right? Only time will tell if the disease has any lasting effect. And I think that's my biggest concern for any of us really, is the unknown.
I think that's one of the lessons we've learned over the last 6 months or so with this. Dr. Welch, any concluding thoughts?
I just want to thank you for having this opportunity, and again, to emphasize, as we've done throughout this entire thing, is that it's really in our hands.
Chesapeake is really and truly, we are very fortunate as a city to have both of you in the position that you're in. You use common sense, you use good judgment, and you stay on top of things, and I just really appreciate you being here today. So, as Dr. Welch said, please keep practicing those safe things to keep this virus down. Thank you for joining us today.